Assalamu alaikum. Thank you so much for allowing me to speak with many friends and colleagues. Thank you, Professor Said Mahmood Saab, who's our teacher, and of course, I'm delighted that Ijaz is on, who was one of our residents at University of Florida and is one of pride of our institution. Um, so let's see, why is it not moving forward? I like to dedicate this to my father, who passed away, as was said. Amongst many other things, he has the distinct pleasure and honor of defending this country, starting when he was in Government College Lahore and volunteered in 1947, and has been part of every time our nation was under attack. So I'm particularly proud of his accomplishments. This Many of those of you have heard this talk before. It's very similar. There's not a whole lot new, but this fine, good-looking gentleman is the person who was the last case of smallpox in the world, and something that I think we, as healthcare professionals and infectious specialists, are pretty proud of for the accomplishment. And this young lady is the first one in the Western world to receive Uh, COVID vaccine in the United Kingdom. And this not so good looking guys, myself, I got my first dose of the vaccine. I was supposed to get my second dose in about 5 days, but obviously we'll have to delay that. Uh, so let me start by showing you this slide. There are actually more than 150 different types of vaccines in the pipeline. However, the two vaccines in the green are the one that are now approved for emergency use authorization in the United States, and the University of Oxford AstraZeneca vaccine has now been approved in UK, and I suspect is going to be presented to the FDA in the not too distant future. J&J vaccine is Janssen vaccine. The one thing significant about this vaccine, it's a single dose vaccine, and then Novovax and Sanofi's vaccine are on the heels for getting approval. There are several other vaccines, but CanSino vaccine and the Sinopharm vaccine listed here are the two that are going to be probably the ones that are going to be available in Pakistan. And I'm going to leave discussion of those two vaccines to Ijaz, in large part because there are no phase 3 trials published. And so it's hard to be objective about the data, and I have no information other than what's published. So as I said, there are vaccines. There are many platforms of the vaccine. There, of course, the ones that are approved in the United States are RNA, messenger RNA vaccines. But as you can see in this list, there are several others. And the Oxford AstraZeneca vaccine is a viral vector vaccine, that particular one. And we'll go into a little bit more detail. I just mentioned about the passive immunity, although not a vaccine, but does provide protection with the preformed antibodies. And there are now two vaccines that are monoclonal antibodies that are approved in the United States, one by Eli Lilly, the other by Regeneron, and they are actually being used right now. But there are several other that are in the pipelines. So these are the two vaccines that are already being used, in addition to the two vaccines in the United States and the third and three in UK. The Sinopharm vaccine is the one that is probably now being used, I believe, in several countries, including the Middle East and then in Brazil, I believe, also. And then there's the Russian Ministry of Health vaccine, the Sputnik 5. And as you can see, there aren't many data, and so I will not be speaking about them much. So what we are interested in is any vaccine, we need to identify something in the organism that we could produce antibodies to. And the coronavirus vaccine, the protein of interest was the spike protein. I'm not going to go into too much detail on that, but just wanted to share this with you. And this particular cartoon shows you the various types of vaccines that are being produced. The BioNTech Moderna vaccine is a messenger RNA vaccine. The AstraZeneca and the Janssen vaccines are the recombinant viral vector vaccine. The Novovax and Sanofi vaccines are subunit proteins. That's the more traditional ones that we may be aware of. And the other vaccines, such as the whole inactivated and live inactivated, there are actually no coronavirus vaccines that fall into those two categories that are, that to the best of my knowledge, are being studied at this time. So let's focus on I like this cartoon because it gets the message, because one of the questions that has been asked a lot, can the vaccine cause SARS-CoV-2 infection or cause COVID disease? And the answer is an emphatic no. The vaccine, so, the way the vaccines are, you have to think about it that if you have a bicycle wheel, a bicycle handle, and a chain, that does not make a bicycle. Similarly, if you have the messenger RNA, a vector, or even an antigen, that does not make the virus. So it cannot cause infection if you get the vaccine. And that's very important. And that's something, unfortunately, even many of the healthcare professionals are confused about. So we need to get that message out. So what are we hoping to learn from these studies that are being conducted, and why is it so important that they be available in the public domain in a peer-reviewed manner, so people in this transparent manner, all of us can review the data. And I think when you're reviewing the data, the most important thing for vaccines is safety, because this is one of the only drugs that you give to healthy people. So the bar for safety has to be extremely high. And of course, then we talk about efficacy. I don't have to tell this group, but it is often confused with effectiveness. And efficacy is what you see in the trials, and effectiveness is what you're going to see when the vaccine is used in practice. The vaccine does create an immune response that in this particular case against the two vaccines that are being used now, actually all of them against the spike protein, and that antibody production then protects the individual when they get infected by the real virus. The question comes up again and again, can the immune response protect against infection? We know that the two vaccines actually that are already being used, the Pfizer and the Moderna vaccine, protect against disease, and it may protect against infection, but rarely there are no published data to suggest that if they're going to protect against infection also or not. And there's some data being shared right now about Moderna that the AstraZeneca vaccine is thought to be protective against infection, and we'll talk a little bit more about it because that becomes very important. And then, of course, does the vaccine continue to show that it is safe when tested in thousands of people? Yes, in thousands of people, the safety of the vaccine has been shown. When you give the vaccine to 33 or 60,000 people, you're going to see some side effects. But when you give it to 300,000 or 600,000 or 300 million and 600 million or even 7 billion people, you are going to find some other side effects that are rare that were not picked up in the trial. So we need to be cognizant of that and be prepared to identify that. And at least in the United States, there's a very good system to follow post-vaccine. And how do the vaccines continue, side effects continue to be well tolerated? And I'm going to talk a little bit about that also in a minute. And we really don't know how long the protection is. The data that were submitted both in the UK and the United States do show that the vaccines are safe and efficacious at 3 months. There's some data now at 4 months that we are a part of the COVID Vaccine Prevention Network. And we had some data last week that's showing now that the protection is even longer. And I'm going to mention here, when you're looking for protection, people think about it as an immune response. The immunogenicity is very important. That's the surrogate for protection. However, the real proof of the pudding is in the efficacy, how much disease and infection it can prevent. And so that's what we really want to look at. Again, I'm going to use this cartoon. I love this cartoon because it helps me understand it better. Here are the pieces of vaccine. Consider them like a sandwich. For messenger RNA vaccine, there's the genetic code, and which is the recipe for the sandwich. And then you have these pieces of bread, which are the vector, which is used to put the messenger RNA in it and then deliver it to the individual, just as the breads deliver the meats of the sandwich. And of course, the meats are the antigens. And then in some of the vaccines, like the Sanofi GSK vaccine, they have adjuvants in that. And you can think of adjuvants that enhance the flavor of the sandwich, and they are the condiments, and they make the vaccines more potent, if you will. And that's what some of the vaccines are using. This is not a new phenomenon. Adjuvants are used in several other vaccines. I really like to show this slide. These are two Turkish Muslim husband-wife couple, Ugur Hussain and his wife Özlem Tursi. They are the ones who founded Biotech, and the company is based in Mainz. There's a lot of other wonderful pictures about this young man when he migrated to Turkey in the 70s without his shoes on. All right, so let's talk a little bit about what are the Moderna and BioNTech Pfizer vaccines. As I said earlier, they're both messenger RNA vaccines. Messenger RNA vaccines is a concept that scientists have been working for years. It's not a new thing. It's the type of vaccine that is also being studied for cancer treatment. And so one of the reasons we were able to use this platform rapidly for coronavirus vaccine because of decades of research for messenger RNA platform. And one of the advantages of this over the traditional vaccine manufacturer is that the time period for developing this vaccine is much shorter, and you can produce a lot of it in a factory. So the Moderna test, the experimental vaccine that they use, the messenger RNA is called 1273, and BioNTech Pfizer is BNT 162b2. These are just numbers that really the labs used to identify the various products. For example, for the BioNTech Pfizer, there were many, and both for Moderna, there were many messenger RNA prototypes. And for BioNTech Pfizer, they took 162b2 and 162b1 to phase 1 trials, and they found that in the animal preclinical trials even, and they found that the 162b2 is probably the more promising, and that has subsequently borne out. Both these vaccines use 2 doses, Moderna at day 0 and day 28, and BioNTech Pfizer at day 0 and day 21. That's how the studies were done, and that's how the vaccines are being given right now. All right. Again, Moderna was evaluated for disease at 14 days starting 14 days post second dose, and BioNTech Pfizer for day 7. Now remember, they look for disease, mild, moderate, or severe disease, not necessarily the presence of infection. So that becomes a very important part as we move forward in fighting this pandemic. And so I think that's something you have to keep in mind. So the Moderna and BioNTech vaccine sandwich recipe is basically the genetic code. Both vaccines deliver instructions for making antibodies against the SARS. What they really deliver is the messages to produce the spike protein, just a protein for SARS-CoV-2. And once inside the human cells, the messenger RNA is delivered there, and it sort of hijacks the RNA of the cell, and they're only in the cytoplasm, and the ribosome, the protein manufacturing part of the cell, then starts producing these proteins. And then they display it on the surface of the cell, and the immune system then goes into high gear, and it recognizes this protein as foreign, and then creates antibodies, and in response to the presence of this antigen, which then helps block and fight off the infection. So it's a little bit more complicated than I'm mentioning, but I wanted to simplify it so I can understand it myself. Of course, there are B cells involved, there are T cells involved. There are a lot of studies going on to save their memory cells, which will help us understand whether we need the vaccine every year. That's not the only factor, but that's one of the factors that will determine if we can get the vaccine. We need the vaccine once, or we need it every year, or whatever the schedule is going to be. So again, I mentioned this earlier. This is an extremely important point. The replication of SARS-CoV virus in the body is infection, and infection may or may not cause symptoms. And as we know that in COVID-19, a large percent of people are actually asymptomatic. And however, even though you are asymptomatic, if you have the viral infection, you have viral shedding, and hence you can transmit this infection to other people. And so that is why I keep on stressing that these vaccines, what we know is that they prevent disease and not infection. And of course, disease is the clinical manifestation or the symptoms that occur because of the infection. So the idea of this vaccine was that how many hospitalizations can we decrease, how many ICU admissions, how many intubations, ventilator use, and how many deaths. That was the point, not if the people were infected or not. So there are some potential safety concerns. There are a lot of questions in people's minds about COVID-19 mRNA vaccines. And some of these are being evaluated now, and some will be evaluated in the future. What we do know is there are local and systemic inflammation in this vaccine. But that occurs in most vaccines, and I'll come back to that in a few minutes. There's a question of where the immunogen is distributed and how persistent is the immune response. Can it stimulate auto antibodies, auto-reactive antibodies that may cause autoimmune diseases? And are there any toxic effects of the non-native nucleotides? These questions are being carefully evaluated, and especially in the what would you call post-marketing or phase 4 studies, if you will. But at least in the United States, the CDC, I got my vaccine. I had to sign up for this app, and I got a message for many days now. I'm getting messages asking about if I'm having symptoms, any problems. So they're sort of trying to keep track of that. Anytime you have any vaccine, but especially COVID-19 vaccine, there are some critical issues. And the critical issues are, is the vaccine safe? What are the adverse effects of the vaccine? And what is the efficacy of the vaccine? Of course, safety is high on everybody's mind. And of course, as important are the tolerability of the vaccine. You may have a terrific vaccine, but if people can tolerate it, it's useless. And reactogenicity, that is something we expect. We expect of vaccines to be reactogenic. That is not necessarily a bad thing, but it is something we need to know. We need to know ourselves, and we need to be able to tell our patients so that we can manage the expectations. If people know what to expect, they are less likely to be concerned about it. So I don't know how many of you have had the Shingrix vaccine. I had it. Now I've had the other vaccine also. When I got the Shingrix vaccine, that's the shingles vaccine by GSK. I felt pretty crappy. I was like lying in bed for at least one day. My arm hurt. I feel like I'm coming down with something. So I got the vaccine on Friday, and on Saturday, pretty much I felt really bad. For the COVID-19 vaccines, the one messenger RNA vaccine, it is thought that probably the lipid nanoparticle, that's the capsule that is used to deliver the messenger RNA, is the one that causes the reactogenicity issues. So as I said, we need to be prepared to manage expectations. You can have fever as high as 39 to 40 degrees Celsius. You may excuse me, you may feel fatigue. There's going to be site injection, will have pain, tenderness, swelling, redness. You may have joint aches and muscles, pains. And you basically, as I jokingly say, the scientific term of all these is that you're going to feel crappy. I'm not going to go into detail for these two vaccines, but they're just to remind people that their reactions after the first dose and second dose, both in the Moderna and the Pfizer vaccines, they're mild and moderate signs, symptoms, but there may also be some severe, and they seem to be a little bit worse in after the second dose than with the first dose. And this slide gives you some idea about comparison of the side effects or reactogenicity. And as you can see, and you can go over the numbers, I'm going to skip those, going through them for favor of time. But if you look at the bottom row here, Shingrix has more side effects, more reactogenicity than the Pfizer COVID-19 vaccine. And it is a little bit more than, however, COVID vaccine, more than what you see in the Flucelvax vaccine. And mind you that you get some reactogenicity even with placebo. So I think that those reactogenicity are mostly local pain, but you can see here fatigue, myalgia, headache was present in quite a large number of individuals who got placebo vaccine of the arm of the studies. So just keep that in mind, and then we need to just tell people to be expecting this. I'm not going to go into this detail, but each society, each country, each jurisdiction has to decide who's going to get the vaccine. Our hope is it is decided in a ethical manner, and that people at high risk get it first. As all of you know, in the United States, it has started with the healthcare workers, and now we're giving it to individuals more than 65 years of age, and we are spreading it to various groups with the hope that by February, March, everybody would be able to get the vaccine regardless. So I think the allocation, as I said, hopefully based on ethics, but it also has to be based on science, on what we can implement, and of course, importantly, ethics. And the science basically, who has the most disease burden, who's going to provide the biggest bang for the buck, if you will. It's a balance between harm and benefit. The healthcare workers, the first responders in the United States got it first because we want to make sure that the healthcare system is stabilized. And because there's a risk we are only concerned about that the healthcare system may fracture. I can tell you when I got to Pakistan, I got a text message from our hospital that we are in what we call red zone. Our capacity, hospital capacity was at 98.5%. So I think that's something very important. And of course, how you can implement it. It is easier for the hospitals to get the vaccine, at least in the United States, and give it to healthcare workers first. But now we are distributing it through the long-term care facilities and to the departments of health. Finally, ethics. I think this is important. We have to promote justice. This is where also we as pediatricians are advocating why children should also get the vaccine. The studies in children are starting right now. Actually, Pfizer is already enrolling children as young as 12 years of age. The Pfizer vaccine is approved in the United States for 16 years and older. Moderna is 18 and older, but Sanofi is also starting studies in children. But right now we're looking at 12 years and older. We are a part of several of those studies. We want to maximize benefit and minimize harms. Mitigate health inequities. And what basically means is just because you have resources, just because you can buy a vaccine is not the reason you should get the vaccine. And we have to promote transparency. To be very honest with you, I'm very concerned that what may happen in the under-resourced parts of the world where there's going to be limited amount of vaccine, and then it may cause negative impact in the sense that certain privileged groups may get the vaccine first rather than the ones who need it first. I wanted to use this slide. It's a busy slide because we get lots of questions about whether vaccine can be used in pregnant women. You can read these slides. I'm not going to read it for you, but in the United States, at least, two groups, the American Congress of Obstetrics and Gynecology, ACOG, and the Society of Maternal Fetal Medicine, they have both recommended, as did the CDC, that with pregnant women should be offered the vaccine and that they should discuss with their healthcare providers whether it is safe or whether they should get the vaccine or not. At least in my experience, limited experience, since the vaccine has become available, most of the, if not all, healthcare providers have recommended the vaccine for pregnant women and lactating women, but also women, other people with underlying health conditions such as autoimmune disease. Even though there were 23 pregnant women, well, the pregnancy was an exclusion criteria in all these studies. In the Pfizer studies, 23 women got pregnant while on the studies, and in Moderna, it was 6 women, sorry. So the number of pregnant women receiving these vaccines is very limited. Those women are being followed for the outcomes. But there is no biological plausibility why this vaccine may cause a problem in pregnant and lactating women. So it is recommended that if they are otherwise eligible for the vaccine, that they should get the vaccine. Some of the things what vaccine does and does not do. One dose does not protect against disease. You need a second dose. Of course, once the J&J vaccine comes out, that's only a single dose. And that, in my mind, is going to be a big advantage for using in parts of the world where the resources are limited. Vaccinated people may get infected and transmit the infection. Standard coronavirus protection precautions such as facial covering, social distancing, and smart isolation still apply. And long-term protection is not confirmed. All the participants, at least in the studies that I'm conducting, are going to be followed for 2 years. There may be some possible unknown risks. There are always that situation. We have local and systemic inflammatory responses. And again, there are other factors that we will only learn with time. I want to spend a couple of minutes on looking at how does the messenger RNA vaccine work so that people can feel comfortable in saying it's not going to change your genetic code. So think of the messenger RNA like a USB drive, right? And just like in a computer, it is inserted, the messenger RNA is inserted in your body. And it does not, the USB does not impact the hard drive. And in the same way, the messenger RNA of the vaccine does not affect your genetic code. But just as the USB runs the program, the messenger RNA helps produce the antibodies to the spike protein. And then when you remove this USB drive, program is gone. Same way, once the messenger RNA does its job, it's gone. So it cannot impact anything else. So I think hopefully people understand and get that message out there. The DNA is where you store it, your genetic code, and the mRNA is where you have the software, and the protein that mRNA produces is the application, and that's what is important to understand. Quickly, I'm going to go over some of the other concepts. The AstraZeneca Oxford vaccine really uses the vector that they use is a chimpanzee adenovirus that does not cause infection in humans, but there's of course concern about that. I'm not going to go into that, but there was this mystery thing about that when they inadvertently gave half a dose of what was scheduled to be given for the first shot, those people had a better response after they got the second shot, and they placed the concept of priming and such, which I don't really have time to go into today. When you think of AstraZeneca vaccine, think of it as basically in the sandwich, a vector which has an antigen in that. The vector delivers the vaccine to the human body, and then it basically does not do anything else. The vector is the chimpanzee adenovirus. The antigen is delivered, and then causes an antibody response. The Janssen vaccine, which the big study is the ensemble study, it's also a DNA vaccine delivered by the chimpanzee adenovirus. I'm not going to go into details, very similar to that. Again, the vector is the adenovirus and then antigen. Now, keep in mind that these antigen, the messenger RNA, the antigen of these vaccines, these are all produced in the lab, so they cannot really give you the infection or the disease. Oops, sorry, I'm going the wrong way. I already talked about this. Then there's the Novovax vaccine. Let me go to the next slide in favor of time. Basically, in this sandwich, you have the antigen, and then you have the adjuvant, which is matrix M in the Novavax, and in the Sanofi vaccine, it's a different adjuvant that has been used in other influenza vaccines. I'm rushing through these slides, so there's time for Ijaz to present and time for questions. I apologize for that. Same way, the Sanofi vaccine, the antigen is there, and you have the adjuvant AS03, which is used in other vaccines also. Well, we will tell our grandchildren, here's what I think would happen, my hope will happen is this young man is asking the mom or the teacher, whoever, what's that mark on your arm, mama? And my mother says, it's my smallpox vaccine scar. And those of us who are old enough have two scars. I have two. One is for BCG, another is for smallpox on my upper arm, and I also have in my forearm some scars from last smallpox vaccine that I got in the 70s. And the young man asked, why don't I have one? And she said, because it worked. Hopefully we'll be able to tell our grandchildren, or our children will be able to tell our grandchildren how we were able to succeed fighting this pandemic and getting rid of it because the efforts of everybody like you on the call and many, many others. So I want to thank you all for your attention. And I know, I believe we are going to answer the questions at the end, Dr. Saab, or are we answering them now?
I think if you allow, we can have presentation